Hello, everyone. Welcome to Move Daily Talks. I'm your host, Tracy Steen, and today I'm welcoming menopause expert Amanda Thebe. Amanda is a fitness and women's health expert. She's the author of Amazon best-selling book, Menopocalypse: How I Learned to Thrive During Menopause and How You Can Too. With nearly 30 years of experience in the fitness industry, Amanda is a highly regarded expert on women's fitness and health. She is the co-founder and chief wellness and branding officer at Naya Health, a complete healthcare solution for menopausal women in Canada. In fact, she's Canada's first menopause workplace educator. Through menopause advocacy and education, Amanda provides on-site or virtual presentations in the workplace to improve productivity, retention, and attendance for female employees, helping companies to normalize this conversation around menopause and provide support, which impacts 100% of their female employees. Amanda is married with 2 boys and lives in Toronto, Canada. Amanda is also an affiliated member of the Canadian and North American Menopause Society. So, needless to say, Amanda's got some experience in the pause. So, I'm really happy to have her on our show today. Welcome with me, Amanda Thebe. As you folks know, in the season, we are in the pause season. You know, I have one friend who calls it the sacred second act. And so often I feel like people just hate this season of life. I hear lots of negative things about this season, and I know that Amanda thinks differently. So I'm really excited, Amanda, to hear what you think about menopause. And don't you think that's true that a lot of people are hating on this season of life?
Although I do think maybe that's changing, hopefully. I do know, Tracy, that it does come from a historic place. Like I've dug into this and I wanted to know, why is there so much shame and stigma and taboo around a topic that we're all going to go through, females, if we live long enough? And it definitely comes from a place of the past, like in Victorian times, we would be stuck in like a sanatorium if we had hysteria, which was essentially going through menopause, had our ovaries removed just to make us normal again. And even in the 60s, we were sort of over marketed hormone therapy at the time just to make us more pleasant to live with for our husbands. And so it's got this history that's patriarchal and full of misogyny. But I actually think now that the Gen Xers, I don't know if you're quite there, but I'm definitely a Gen X. We've had enough. And I think we're just like, why didn't anyone tell us about this? Why are we too embarrassed to talk about it? Let's sort of make some shifts. And I know I've been talking about menopause since my own personal experience when I was about 44. And so in the 10 years that I've been talking about this, I've definitely seen the needle shift, thankfully.
Yeah, I have. You know what? You're right. I totally have too. I'm also, are you 54 then? I'm 54.
Yeah, I'm
Uh,
not. No, I'm 53. I
Okay.
don't know why I do. Do you do that when you're menopausal? You forget how old you are
Oh my
and you
goodness.
can't do
Yes.
math. Yeah.
Well,
Well, you
lucky I
look
was born.
good. You look good on it.
Oh, well, lucky I was born in 1970. It's easy to calculate for me. Um,
Yeah, me too, but I'm not quite 54 yet. Yeah.
Not yet. Yes. No, I love that the conversation is shifting. And you're right. There has been this stigma. I hear a lot, like I look in my comments all the time, and a lot of people are complaining about the shift that is happening in their bodies. And I think maybe possibly just not understanding what to expect. And then all of a sudden it's here and they don't know maybe some of the strategies to manage or work with what's happening in their bodies. So that's obviously why I have you on today as well, because you've got a lot of strategies, a lot of tips, a lot of methods and just ways to look at menopause and how to move through it, but in a way that we are thriving. So I'd love to hear your own story of that journey. How did you go from maybe a season where it,
Bedridden,
yeah, wasn't
bedridden to
enjoyable, oh,
functional.
bedridden even, yeah, to thriving throughout this season of life.
Yeah, and I have to say, Tracy, that I believe that every woman has a better chance of having a better perimenopause experience if she has knowledge. And
Yeah.
one of the problems that we have in this conversation is there's a massive knowledge gap that was never filled by, say, our mothers, our aunties, or our grandmas because of everything we've just spoken about. We don't get taught it in school. In fact, we sort of fall off the reproductive cliff after pregnancy in those school books, right? We don't even hear about it. Also, it's sort of like a time of a woman's life where other stuff is happening and it doesn't seem to be at the forefront of our minds. There's so much happening with our parents, our kids, our career, etc. And I know for me, going through my 40s, when perimenopause hit me, I had 2 years in sort of the medical system here in Canada. They desperately wanted to help me, I might add. I had very good doctors, but nobody was joining those dots for me. And so from the ages of 42 to 44, I was a mess, a complete mess. I didn't recognize myself. Felt really, really ill and was frankly quite worried about my health. And then I went to a gynecologist about something completely different. And he said to me at the end of it, "So is everything okay?" And I started crying like you do when everything's not okay. And he just said to me, "You're in perimenopause. I recognize these symptoms of depression and migraines with aura. They were leaving me with vertigo, sickness, lots of body numbness, um, incontinence that came out of nowhere. All of these different symptoms he recognized and said, and I can help you." And I just thought to myself, well, phew, I don't have a brain tumor. And I was just like, but how come I didn't know about this? I mean, I've been in the fitness and wellness industry probably as long as you. It's like 35 years now, and we don't get taught it in any of our educational modules. Well, you can get it now, but all the time I was going through this, I'd never heard about menopause, only the myth that it was for older women and, you just stopped getting your periods. And so I frankly, got a little bit annoyed and just thought, I need to know everything about this and I need to share this because if I'm going through this, then obviously other women are going through this too. And I started a community on Facebook called Menopausing So Hard. And I think there's about 25,000 women in there now. But every single day, a new person comes in and they don't know what menopause is, perimenopause is, and they're confused and they cannot advocate for themselves. They don't have agency because they have this knowledge gap. So that's why I wrote my book, because I thought I have to just share the facts with people so that they can then make their own decisions. And so when I talk about menopause, I hate the word expert and I don't call myself that at all because, I'm from a non-medical background. I'm more a patient advocate but I've reached out to medical experts and there's mutual respect there because I don't try and be a doctor. I don't try and give people medical advice. But what I do is I take the current position statements and the medical consensus and I translate that into really human speak and say, well, this is what the menopause societies recommend and this is why. And this is how you can talk to your doctor if you want to have some type of medical intervention, right? And I think every woman should be able to have a valid conversation, whether that's hormone therapy or not, with their medical provider, because no woman should suffer, right? It's a natural phenomenon for most women, but we don't have to suffer. And I'll pause it there because I know we're going to talk a bit more about that. But then on the flip side of that, on the second part of my book, I really drill down into the lifestyle interventions that should run alongside everything we do, medically or not, that sometimes don't feel accessible, especially if you're not feeling yourself, always, always are impactful, as you probably talk about all the time.
Yeah, for sure. Yeah, that's the pregame, right? That's the pregame. You know the things that you have to do, and then that's going to help set you up for a better season of life as you move through that. I think sometimes it's better to be, I mean, yes, we have the health professionals, and of course they are so valued and they have the research and the knowledge and the study and the years. But as the patient, you're doing your own due diligence is what I hear that you have done, which is amazing because I think so often people don't do that. They don't advocate for themselves. They don't do the research for themselves to see what's out there. And it
Or
sounds like,
can't, right?
right? But it sounds
Don't
like your
or
book,
can't, yeah.
yeah, it sounds like your book is a culmination of your years of really doing your due diligence, doing the research, putting in the time. And it's time consuming. There's no doubt about that, understanding all of these things, all of the options, right?
Yeah.
Like you're right. What questions to even ask your doctor? Some of us would just be dumbfounded, kind of going, well, I don't know what to ask. I'll just trust that they know what's best for me. And a lot of times they do know what is best for us, but sometimes they're not as educated. You know, I talked to Dr. Sharon Stills, and she was saying that in her practice, when she was going through university, they were not educated. It was like a 1 hour module on menopause or whatever, right? Or
Yeah, in Canada, there's a massive knowledge gap. And even OBGYNs, only 20% of the facilities for OBGYN fellowships teach menopause. And then it's a quick refresher. There's a knowledge gap, not just with women, but with doctors. And I think it's really interesting because I don't know about you if you had bad symptoms, but for me, main one was migraine with aura and depression. And I didn't recognize either of those two things because they were brand new to me. So
okay.
when I went to my doctor and every single medical professional and every test I had, I always described them the same way, the symptoms the same way. None of them said, oh, that's depression, or that's migraine with aura. And none of them said, and those two things together could be perimenopause because there was a gap there too. And so even though I was really good at advocating for myself, the knowledge gap at both ends stopped perimenopause being the conversation, right? And that often happens too.
I'm interested, actually. I want to ask you just your thoughts. This is a little rabbit trail here, but I also have migraine with aura, but without pain. So it's just the aura. And I had noticed throughout my whole life. I think my first one when I was 16. So it seemed to be very hormonally driven still. It's slowed down now that I'm in menopause, but I still have it periodically. And it seems like it's when the hormones are surging or when it's near my period, not now, but before in perimenopause. But what sort of, yeah, I didn't even think that possibly that was a related symptom to menopause or perimenopause because I had it starting so early. So I definitely think that it's, like I said, a hormone
But it
related
is
thing.
hormonal, and that's why. And so some people have, so statistically, when you look at the data, some women have migraines around their menstrual cycles, and it can sometimes get worse in perimenopause. But normally, they find that migraines get better in postmenopause in like the 3 to 5 year window. And I'm in that now. I mean, I do occasionally still get them. I'd never had them before perimenopause. But during perimenopause, I had them chronically. So maybe I would have 5 or 6 days a month without them. And the rest of the time I had them. So it was pretty debilitating. And now I might have them if there's a little bit of low pressure. And so I actually am on a migraine medication called Ajovy, and it's an injectable, preventable. And I don't even know if I have them anymore, but I'll do anything not to have them again. But most women find that they do subside, as they go into postmenopause if they're hormonally related, but it's very common. And I used to get the worst bit for me was post migraine, like hangover, where I'd get not really bad nausea and my balance would be off and I'd drop things. I just drop everything in the kitchen and then it'd be like, oh yeah, mom's got a migraine again because we've just broke 3 cups again.
Yeah, no, I know. They suck. I don't like them either. Let's jump into advocacy. One of the things that when I said when I introduced you was that you are a big advocate in the workplace for women in menopause, and I want to hear more about that because I think that's fascinating. One thing that it just kind of reminded me of our leaps and bounds, maybe within the Canadian system, possibly North American. I'm not sure what they're doing in the United States or in Europe regarding this. But my husband does mental health first aid instruction. So he goes into the workplace, and now they only used to offer first aid, and there had to be someone who worked there that was, licensed in first aid. But now they do mental health first aid instruction
Wonderful.
in the workplace, which is fantastic. The Canadian Mental Health Association is the founder of that. So when you said menopause advocacy, I'm like, well, let's put on some courses here. What do we need to know about women in menopause in the workplace, and what are you doing in that field?
And the Canadian Mental Health Association, I actually have spoke to the CEO about incorporating menopause into their offerings. So I've already had those conversations because we know that perimenopause can have a huge impact on our mental well-being. And so anxiety, depression, even the brain fog, the migraines, the hot flashes, it's all in the brain and it can be quite debilitating for a lot of women. And what I do in the workplace, I mean, it really depends on the organization I'm working with. Some of them want to know more about the financial impact of not acknowledging and menopause in the workplace, and for women not managing their symptoms. And we have data on that in Canada and globally as well. So sometimes I talk about the cost and burden and legal aspects of it. I always give them like a primer, like a menopause 101. And I caveat that with I'm not a doctor, but I sort of translate the definitions, the symptoms, and the treatment options available. And it's really important to do that because a ton of people have these misconceptions about what menopause is because we have this knowledge gap. So I sort of fill those knowledge gaps in. And then what I'll do is I'll then talk about the importance of lifestyle interventions, and especially things like stress management, improved sleep, exercise, and nutrition, just a balanced nutrition plan and not falling for any of like the fad diets and supplements that are out there. And I sort of do harp on a little bit more about strength training as well, because we have quite a lot of data on how helpful that can be, not just through menopause, but for our overall quality of life as we, like move forward as we get older. And it's always well received. And there's more and more men coming to the presentations. So I always make sure to talk about allyship and how to create solutions within the workplace as well. And the solutions tend to be more like educational resources, how to have compassionate conversation, um, you know, flexible hybrid working hours, maybe cooler, quieter environments. Nothing is crazy out there, but creating like a blueprint within the workplace is actually really important to women, right? And it's working. It's working for them. One in 10 women leave the workplace in Canada because of unmanaged symptoms, and 1 in 5 consider leaving the workplace. So it's quite big numbers.
Yeah, for sure. Compassionate conversations with a spouse or a partner or someone like a boss who's a man. Uh, how are we having compassionate conversations?
Well, the compassion comes from the other side. I mean, for the women, it's just like, are they brave enough to talk about it? And a lot of them. So the Menopause Foundation of Canada is a really great resource for anybody listening. They've done a couple of surveys, and in one survey, 54% said that they are completely uncomfortable talking about menopause. And 87% said they thought that there was no support within the workplace, right? Or if there was, they didn't know that it exists. So there are already barriers to having this before they've even thought about it. So, but I do think that women are becoming a little bit more emboldened now because menopause is becoming more sort of out there, isn't it? Like it's having its time in the sun essentially. And so I think that for me, it starts with the woman trying to have a conversation and open the door with their HR department or their line manager to say, I'm struggling. I need to talk to somebody about this. I need some help at work, because productivity is impacted, absenteeism is impacted, and retention too. But it's how the other person at the other side responds to that, right? And often menopause is seen in the workplace as a lot of jokes. It goes in there with sexism and ageism. It's completely intertwined, and if a woman knows that that's the type of response she's going to get back, chances are she is not going to have any conversation in the workplace. So for me, when I go into these organizations, it's a top-down approach. The company's culture and attitude completely has to change, and there can be no diminishing conversations or derogatory comments about this at all. It has to be something that is completely supported. And then one of the things I sort of say to anyone generally who's not going to go through menopause, right, is that, it's okay to be uncomfortable. We're not looking to be fixed and we're not looking for sympathy. But if we tell you something's not right and we don't feel good or we need your support, then just offer that up. I'm sorry that's happening to you. What can I do to help? In
Yeah.
the workplace, oh my goodness, that's terrible that you're going through that. Did you know that HR has a menopause ambassador that have all these resources and they can help you find a provider? That's all we're looking for.
Yeah,
But on the
wouldn't
flip,
that be amazing if we could
wouldn't
have
that be
that?
amazing?
A
But on the
menopause
flip side,
provider. I
a
like that.
menopause provider or an ambassador, and the
Yeah.
workplaces are doing that for sure.
Yeah.
But on the flip side of this, I have to just give like a big kudos to guys out there because I believe that they would be more involved in the conversation if they had any idea about what was going on. And chances are they don't because we don't, right? So I think a lot of the onus is on the woman going through it to be prepared to have open and awkward conversations. And that includes with your spouse, right?
Yeah. And okay, so now we have women who, a lot of women's personalities tend to be that, uh, which does not rock the boat, which does not have those conversations that are challenging or difficult. We just zip the lip, stay silent, keep it inside, don't cause controversy, don't be a pain. I think a lot of personalities do bend toward that, right? Just being that softer person. And so I think when people can stand up, it emboldens those who maybe are a little bit more shy or who don't like to rock the boat or cause any tension in the room. I think immediately and this is, I think, why it's becoming more mainstream right now, and that we're shifting into a place where we can talk about it. Like I look at people like Oprah and Halle Berry and some of these experiences that they've been sharing about menopause. Halle Berry had did you hear about hers? Yeah. So, right.
Yeah, yeah,
So
yeah,
she went to the doctor and the doctor basically is like, well, I don't know, you're dying. but,
yeah.
but it was really perimenopause or menopause that she was in. And so they speak about these things, and that is creating this. Yes, it's emboldening us to actually speak for ourselves and say, no, I'm not just going crazy. This actually is a symptom of menopause, and people do suffer with anxiety or anxious symptoms
It's
or depressive
normal.
episodes, right? It's not just hot flashes and night sweats. It's all of these other things, or migraines, whatever, right? So it's really opening our eyes to see that there's a lot more going on. And I'm glad that we have some forerunners that can sort of cut the path, as it were,
But
so
that's what's
that,
happened, I
right?
think. You're right. There's been a movement, myself with many others included, that have just decided enough's enough and we're going to talk about it. And it usually takes a little bit of bravery to be able to say menopause or dry vagina on the CBC, but whatever, once the door is open,
Yeah.
you can do it. And actually I think a lot of the time women don't say anything, and this was my case, and I don't know about you, but when I was in the thick of things and I didn't know what was going on, I did keep quiet and I didn't say anything because I felt like I was failing and I felt like quite ashamed that I wasn't able to live up to my previous personality, energy levels, like everything in my life changed through perimenopause. I was a shell of my former self. And I didn't know why, and I didn't want to admit that to anyone. But the people closest to me saw that and they suffered. My children and my
Yeah.
husband and my
Unfortunately, yeah.
friends.
That's right. Everyone
Yeah,
around us
like my
bears the
husband,
brunt.
they do, right? And my husband actually at one point, when I told him it was perimenopause and depression, no, etc., he went, phew, because I thought you were going to leave me. And that's the state that it got to because I couldn't articulate what was going on. And he was left guessing all of these awful things. And I had no intentions of leaving him. I just hated life because I was in perimenopause. And I think that the not knowing and feeling like you're failing is something I hear from women all of the time, being ashamed. And it usually comes because of lack of information. And so that's why it's so important to have these open dialogues, because if you start knowing about it, then you can start making decisions and choices. And the reason I think men should be involved in this, and I did a TEDx called "Should Men Talk About Menopause," and it was based on that conversation with my husband, and it was based on a celebrity doctor that actually railroaded some 20-year-old personal trainer guy for talking about menopause. You said no man should be talking about menopause. And this guy was just saying, I'm here to support you. I've tried to become educated. It was terrible. And I was like, are you joking? We all need to normalize this one simple word, right? And I need my two boys who, when they meet their future partners, or if they have nieces, whatever, that they're ready and it's not going to blindside their partners moving forward. I just think it's so important, right? So nobody is barred from talking about menopause. We all should be.
Yeah, yeah, absolutely. Speaking of menopause, and let's dive into this conversation about hormone replacement, BHRT, bioidentical or body identical hormone replacement therapy, menopause hormone therapy. There's a lot of acronyms out there. Would you care to break those down for us? And let's just have a little discussion about this. And
Yeah,
before we even dive into that, I'd like to say too, I feel like any sort of hormone replacement therapy is an individual decision, right? Everyone's got their own journey, their own path, their own body, how it's going to interact. And these are going to be our opinions. So please do your own due diligence when it comes to supplementing or getting medication for yourself.
yeah, that's a really great point. And I think it's confusing because social media has made this a bigger conversation, and there's people in the UK that have got terminology, there's people in the US that have got terminology. And so let's just break down the terminology. And if this is a Canada really based audience, it makes it a
No,
little bit, it's
it's
not, you've got US.
mostly US. Yeah,
Okay, that's
mostly.
fine. It's
Yeah.
the same thing, right? So the one thing I would just say is you hear the word bioidentical and you hear the word body identical. I just want to remove the word body identical from the conversation. In the UK, to denote that something is regulated, they call it body identical. And it's one doctor that decided that. It's really crazy. Whatever, if it makes it easier for people to understand that, you can get your medication on the National Health Service and it's considered to be body identical. That just lets you know that it's regulated, and bioidentical in the UK is considered to be unregulated. But when we're talking about hormones, the hormone conversation should really be about what's regulated and what's unregulated. And I'm going to start there because I think it's the easiest place to start. So in North America, you've got the FDA that approves medication, and you've got Health Canada that approves it in Canada, right? If it's regulated, both of those organizations can go to the lab where the hormone therapy is created. They can pick any vial off the manufacturing plant. They can test it and it would be accurate compared to anything else they've done. It will always be the same dose, the same efficacy, and the same safety profile. And that's really important to remember, right? Whether the hormone is bioidentical or not doesn't make any difference. If it's regulated, the FDA will and Health Canada will approve it. And you can get bioidentical regulated hormones. And you can get synthetic hormones that are regulated too. But don't be fooled that bioidentical isn't synthetic, because they're all made in a lab. They're all made, they may be, I think the original source is usually yam, but it's shipped in from a German manufacturers and it's synthesized in a lab. So that's the difference. So you've got regulated that can be bioidentical and synthetic. Okay. On the other side, you've got, and I'll tell you about the acronyms in a minute. And on the other side, you've got unregulated hormones. And what happens is a lot of private clinics will say they're going to personalize your hormones for you, and they will take these original sources from the German plant, the estradiol and the progesterone, and they will mix it in a compounding pharmacy in a different preparation. And that's considered to be unregulated because you've taken something that was tested for efficacy and safety, and it's now in an unknown vessel. And that's the difference, right? So if somebody decides to do unregulated hormones, bioidentical hormones, you just have to know that you don't have the guarantee of efficacy, safety,
Right.
and bioavailability.
Is there
So
other
that's,
stuff added to those unregulated
yeah,
ones? Do they
yeah,
they're adding
yeah.
compounds, different?
They will add a different like vessel. It might be a cream, it might be a gel, it might be a spray, it might be a patch, but they're mixing them.
Gotcha.
And the American, oh, now I'm going to get the acronym wrong, but the American Science Commission did an independent review on compounded hormones, right? The unregulated compounded hormones. And the differences, the different methods that they tested was astronomical. Sometimes you got huge amounts of hormones, sometimes you got small amounts of hormones. There's no guarantee at all. It's down to the discrepancy of the compounding pharmacy. And the same goes for pellets. They're considered to be unregulated. And some women get estrogen and progesterone pellets inserted into their butt cheeks that stay there for 3 months and do a time release of those hormones. It's okay if they choose to do that, but you need to know you're choosing to do something that's not regulated, and it cannot be guaranteed that it will not harm you. And in fact, the FDA have issued warnings about pellets from a safety profile. So then let's look at the different acronyms. So we often think of hormone replacement therapy as HRT, right? And HRT is actually a term that's no longer used in North America and Canada, well, just North America, to talk about hormone therapy. If you're over the age of 45 and you get hormone therapy, it's called menopause hormone therapy, MHT.
Right.
HRT is actually typically a replacement of the hormones that you've lost, and they're a higher level. And they're the type of hormones you would get if you went into a premature or very early menopause. And so if you go into menopause under the age of 40, then you're going to go on HRT. They still use HRT as an acronym in the UK, though. So just don't worry about the UK. Let them do their own thing. In North America, MHT is the standard acronym. When you see the B in front of it, the B MHT or the BHRT, that's telling you that that's unregulated. That's the acronym that the private clinics use for their compounded hormones, and that's the difference. So to cut a long story short, it's up to you what you do. I don't care, right? Women get to make a choice.
Sure.
But if you know that you can get a bioidentical hormone regulated from your health provider at a fraction of the cost, because it's usually covered by insurance, I don't know why you wouldn't do that, because you know you've got that safety profile covered. Whereas the private hormones, the unregulated ones, are not covered by insurance and will cost you hundreds a month. And so often private practitioners won't even give women a choice. That's the problem I have, is when women aren't, it isn't explained to them properly. Ultimately, you've got to find what works for you.
Yeah.
And then can I say one last thing?
Yes, please.
As far as the menopause societies are concerned, they recommend regulated hormones. They do not recommend unregulated, right? So from a medical standpoint, they're very clear. And they also let women know that not everybody should or can take hormone therapy. And comes down to exactly what you said, Tracy, in the beginning. You need to determine your risk profile, have an assessment. Are you a candidate for hormone therapy? If you are, what type do you want to take? If you aren't, what are the other options? And if you don't want to, that's fine too, right? It really is an individual sort of like choice. And I am a good example of it, because I really wanted to go on hormone therapy, and it was dreadful for me. It made my symptoms so much worse, made my migraines worse, made me suicidal. It was horrible experience. And that's not unusual, right? It's a drug.
Right. Right. So, I mean, this is where you have to be in close conversation with your healthcare practitioner and make sure you do your due diligence with the follow-up, right? If it doesn't feel good, if it, like you're saying, increases the symptoms or makes things worse, then that's where you're going back and saying, okay, let's switch things up. I've had friends too that have gone multiple times. Yep, this is not working. So going back, round 2, round 3,
It might
right?
take a
It's
while,
not,
right? It might
yeah,
take 3 or
right.
4 different rounds. It might actually be that the dose isn't appropriate for you, and they can play around with that. Having a solid doctor to have these conversations with is such a blessing. And it's really hard to find those. That's the problem, right? But if you do find one, like, hang on to them for dear life, for sure, because you really want someone who cares about your health ultimately.
Yeah, I know in Canada, if you have a doctor and you want to switch, you can't. There's no one else to switch to.
We're
You-
like 1 in 8 now for a GP. 1 in 8 people have a GP. That's shocking.
Wow, that's shocking. I know one of my friends, I feel so bad for her because she does have issues like autoimmune disease and she has no family doctor. So she's going to walk-in clinics and trying to get care. And it's just ridiculous. That's
Brutal.
not good.
That's brutal. Yeah.
Yeah. Let's dive into some lifestyle conversation here. Of course, I fully believe that lifestyle is so key, and there's just so it's multifaceted, right? It's not just fix your nutrition, fix your exercise. There's lots of other factors going on and in play here. So, what would you have to say about the importance of really dialing in those lifestyle factors?
I mean, I think we could probably do a whole podcast on this,
Yeah.
right? But here's the thing, right? I first of all sort of want to acknowledge that, I know a lot of women when they're going through perimenopause really struggle, right? And when they struggle, the idea that I'm saying, you need to strength train and you need to do 150 minutes of cardiovascular work and you need to eat a balanced diet, blah, blah, blah. They're going to be like, screw you. I couldn't even get off the sofa today to get a cup of tea. And so and I've been there, and maybe you have too, like in that situation where chronic fatigue takes over and the idea of doing a workout's just not accessible. And it's really hard to focus on the importance of those when you don't recognize yourself and you don't feel yourself. And so let's say a couple of things, right? First of all, if you already know perimenopause is coming, then you gotta do all the work preemptively. You've already said that being proactive in your health is key. Doesn't mean you're not going to have symptoms because you may. I was super fit and super healthy, and I still had the shittiest time, but it sort of gave me an underlying like level of health that meant that my health never really suffered. Like I didn't have cardiovascular issues, I didn't have problems with a huge amount of weight gain or joint pain and stuff because I already had like a good foundation. Um, but I always like want to say to women, you can't like green smoothie your way out of this. Like if you're going to get hit with symptoms, it's so multifactorial. It could be genetic, it could be lifestyle, it could be your ethnicity, it could be your social economic status. But when it comes to lifestyle interventions, there's certain things that are going to make it worse. And the things that are going to make it worse is if you're sedentary,
Yeah.
if you're overweight, unfortunately. I know we don't like to harp on about weight, but if you're obese, for example, you probably have worse symptoms. If you're stressed all the time, if you're
Yeah.
chronically stressed, stress makes everything worse, everything worse. And stress is inflammatory, and menopause is inflammatory, and it's like it's a lot for the body to deal with. And if you're not
Yeah.
sleeping, you're screwed. Like to
Yeah.
me, that's the first place to
Oh,
start,
yeah.
right?
That
If
is
you look
foundational. Absolutely. Yeah.
foundational, and what's the first thing that happens in menopause for most women?
Yeah.
They get insomnia, right? So they either can't fall asleep, or when they do fall
Yeah.
asleep, they wake up and can't get back to sleep, right?
Yeah.
So like
Yeah.
dealing with the sleep issues to me is one of the main things to do, because if you're not sleeping, you're stressed. If you're not sleeping, you've got increased cravings and it's messing with your hunger hormones. If you're not sleeping, you're not exercising. It's everything, right? Yeah.
Preach.
Preach.
Absolutely. Well, I always say that too. It just impacts every other thing so drastically, right? That it's just it has to be that core foundation. When thinking about stress, I don't know if you ever read that book, The Telomere Effect. It's a
No, I've
wonderful
never
book.
even heard of it.
Okay. So telomeres are the little caps on the end of each
Right.
chromosome, and it's kind of like the little plastic piece on the end of each shoelace. And when we have longer telomeres, it indicates longevity. When we have shortened telomeres, our lifespan is shortened. And I'm trying to think of the late Epwell, I think is the author's last name. There was two ladies that wrote it, two doctors. Anyway, so they did this amazing study with women who had ill children. So terminally ill children, they were caregivers. And what they did was they looked at these caregivers and followed their lives over the period of maybe 6 months and looked at their telomere length. And what they noticed was that women, the lion's share of the women who had this chronic sick children and that low line stress that was day in, day out, all day long, had very shortened telomeres due to the stress impact. Now, there was a few women that actually had lengthened telomeres, so they were shocked at that. They thought, well, why do some women have this longer telomere length? And when they followed them, they went into their day by day and saw them again caring for terminally ill children or parents or what have you, something that would cause heightened stress for anyone
Yeah,
in
for
that
sure.
situation. But what they noted about these women is that they looked at the stress of it all as something to overcome, as a task to be accomplished, as uh, like an Olympic runner would see a long distance run and be ready to tackle it on, kind of like that Superman stance where they're like, okay, bring it, bring on the day, bring on the stress. I've got this. And so their idea of how they approached the stress severely impacted their telomere length and longevity. I
In a
just thought
positive way.
yeah,
It's
totally
lovely.
positive. I just saw that it
Yeah.
was so amazing, that study, just to look at how that stress, that low-lying chronic stress that can enhance at this season of life, right? So you're perimenopause or menopause, which means your 40s, 50s, 60s, and now you have, possibly graduating children, maybe you have kids leaving the nest, which can be a stressor, maybe you're moving, maybe you have a relationship that's deteriorating, maybe you have aging parents or parents who are dying. And all of those things can put this
Yeah, it's a
incredible stress.
smorgasbord of happiness, right? And it's sort of
Yeah.
all like it fills that stress bucket to the hilt, right? And then on the second side of that, Tracy, you've got this high stress environment that causes all sorts of issues. And then you've got social media influencers saying, and don't exercise because exercise causes stress. And it drives me crazy. And it drives
Me
me crazy
too.
because what's the one thing you can do to improve your stress response?
Yeah,
It's
exactly. Move
move
daily.
more, move
Dr.
daily. Yeah.
Stuart Phillips was just on the show the other day, and we
Oh no,
talked about this.
was he? I love Dr. Stuart Phillips. He's
I love him
awesome.
as
Yeah.
well. I know. So we talked about this because I said, well, here's the thing. People are constantly saying, well, I can't do high intensity exercise or I can't exercise because cortisol and it's going to get my belly fat. And he's like, I just don't see it. And then so we had this conversation about that stress being so beneficial for us, and that when we have a workout that's intense, and not to do it all of the time, of course, but intermittently, maybe throughout your week, that those cortisol of us are able to come down, right, and reset the baseline in essence. And it's that other stress that I just referred to, which is the stuff that can be like dripping cortisol into your system consistently, and which could lead to an increase in belly fat and, of course, inflammation and all of the other things. So I was very happy to hear that he was like, yeah, I just don't see it in the literature. I'm like, yes, let's
It's
keep
not there.
talking.
It's not there in the literature. And it's the difference between acute and chronic. And the acute stress actually helps you to be able to respond to cortisol levels in a
Yes.
really healthy, functional way. And so it just blows my mind that like if you were to say even just going for a walk is one of the best things you can do if you're chronically stressed and you're not sleeping, all of the things, right? So for as far as menopausal women are concerned, like there are so many things that they can do, but like to me, if you're not sleeping and you're highly stressed, try and move some big rocks to sort of deal with those. And those big rocks are not hard to do. You've just got to do them, and you've got to do them religiously. Consider doing some mindfulness, right? We
Yeah.
know that that works. That
Yeah.
changes the brain, like it changes the structure of the brain. Go for a walk, be outside in nature. Um, Try and improve your sleep hygiene, right? I mean, that's easier said than done going through perimenopause, but we do know that it works, especially things like CBTI. Like there's tons and tons of data to show how that can help improve sleep hygiene and all of those bad habits we've been doing, like reading our phone in the middle of the night, like they gotta stop. You just can't do them anymore, right?
Yeah.
um and then to me, once you've got those foundational things in place, you can start doing other stuff as well, because you're probably going to feel more energetic and more likely to want to do them, right?
Yeah. Yeah, for sure. We know that strength training in menopause is so important. Why do you think that it is so important and we should be doing it?
Yeah, so how long you got?
Yeah.
So I mean,
Amen.
it's funny because this is when I am really biased. I can't come at this from an unbiased standpoint because I honestly don't see any downsides to strength training. I don't, right? If we're looking for that, like a eternal youthful pill, which I hate the term, but strength training's that thing. Strength training is the thing that's going to keep us going forward with improved longevity, with quality for the rest of our lives, right? And so you probably talked about this with Dr. Stuart Phillips, right? But we know sarcopenia is the decline of our lean body mass, and it happens from our 30s onwards, usually because we're getting older and because we're sedentary. And so we can't do much about getting older, but we can do a lot about being sedentary, right? And we're losing that at a rate of between 3 and 8% per decade. And then through menopause, that accelerates slightly. I think the figures I've read are about 10% per decade, so 1% per year. We start to lose our lean body mass unless we do the most important thing we can to preserve that. And then in addition to that, we also see an accelerated bone loss through the menopause years. And there's about a 10-year window for both of these things where there's like almost an accelerated series of this before it settles down and becomes a little bit more robust. And that's just the body going through this transition. And so we're losing some bone health and we're losing some muscle mass. So what's the number one thing we can do to support that, to either prevent that happening or build new bone and muscle? And that's strength training, of course.
Yeah.
And so nothing comes close, nothing.
No, no. And I think too, just really forward thinking, like what do you want to be? How do you want to show up? What do you want to be able to do in that marginal decade, as Dr. Peter Attia talks about it as that last 10 years of your life? If you want to be able to still hike or golf or go for a bike ride or pick up a grandchild, what will you have to do today in order to ensure that those muscles are ready and prepared to do that 10, 20, 30 years from now? And I think we just sometimes don't think about that. We think, well, I'm okay today, right? I don't have cardiovascular disease today or diabetes today, but I quoted this the other day, as JFK says, the time to fix the roof is when the sun is shining.
Oh my goodness. And it's exactly that. Like it's like, although the good news is, and that study that only came out 2 weeks ago showed that we can still build muscle. This was done in older people. We in our 60s and 70s. We know that that's a case, and we also know we can build it in menopause. I don't care what anyone's saying on social media. You definitely can. You do not need estrogen to build muscle. It's part of muscle protein synthesis. So when we start to lose estrogen, we've got to try and compensate for that somehow. And we can do that by strength training and by eating adequate protein. We know that. We have the data it's not even arguable. So regardless of whether you're on hormone therapy or not, strength training is so great for that. But you've already touched on it. Because strength training changes us on a cellular level, there's data to show that it can improve our brain health. It's now part of the protocols for treatment of anxiety and depression. It's part of the national guidelines now, as well as the 150 minutes of moderate exercise a week. It's 2 sessions a week are the minimum recommended amounts of strength training that people are expected to do. And like probably 80-90% of people don't meet those, right? It's really good for reduction of disease or mitigating some diseases as well, right? So we actually have got tons of data to show how impactful building muscle and strength training is in menopause. But we also know that from a longevity standpoint, it can actually increase our longevity as well. And the last sort of part of that probably pulls into the Peter Attia like functional story. And it's just that we understand that as we get older, we start to become frailer and we fall, and it's falling that's sort of killing us. It's putting us into emergency, it's putting us into nursing homes, breaking our bone. 40,000 women a year in America break their hip and will die as a result of that. Right. And that's more than women that die of breast cancer, because we have treatments for that. And so if you know that you're going to fall and you can't get back up, or you're going to fall and you're going to break something, you can do something about that today. and you can do that. And we know that it's never too late to start, right?
Absolutely. No, I talked to Dr. Stewart about that. Like, is it too late to start? Is there a time period? And yeah, no, it's never too late.
Yeah,
I know
no.
my
Yeah,
my
no.
mom, yeah. My mom is the prime example. She started strength training at 70 and is going on hikes and, bike rides with us all the time. And at 75, 76 now, she's stronger than ever. So definitely
Oh, I
never
love
too late.
that.
I know.
And
It's
and Tracy, do you talk on your podcast about sort of the entry level to strength training as well? Because I think that that's one of the barriers to a lot of women is they think, oh, I don't want to go to a gym with all of those big smelly men grunting. It's intimidating, and I don't want to lift heavy weights. But it looks different for all of us. You're not going to train the same as Tracy and I train because we've been doing it most of our adult lives. If
yeah,
you've never done it before, you're doing push-ups on the kitchen counter, and that's counting for a lot, right?
yeah,
Probably what
yeah.
your mum started doing, right?
Yeah, to take it from like if you're at zero and you start even later in life, you're going to see tremendous gains. You're going to see just, a tremendous improvement overall. And that's the thing too. We always want to be able to show up again tomorrow. So if you are starting a new protocol, start light and work your way up. Plus, you can build muscle with lighter weights. What we talked about in a podcast previously is that you need to continue to challenge the system. So, right, start easily, start light, work your way up, and once it's too easy and you're like, okay, this is easy for me, I can do this, challenge the system because you're not going to progress forward if you stay with the same protocol, right? So there has to be a period of time that you need to progressively overload the muscles. And you can do that with lighter weights, higher reps. It doesn't have to be, a
Yep,
clean
and
and
your
snatch
body.
with a barbell, right? It can be
Yeah.
lighter weights, but that's the caveat is that you still need to challenge the muscle on some level. So yeah, lots of ways to build.
And I
Yeah.
always think as well, so those newbie gains are amazing. And I wish I
Yep.
could get them because they're
I
hard to
know.
get when you've been practicing for a while. But also, like, I'm also a big believer of just doing something. I don't even care if it's strength training. Yes, ideally, I'd love all women to strength training, but actually feeling capable and showing up and turning up, like you said, is part of the puzzle. And so, if that's Zumba, if that's Aquafit, if that's pickleball, I don't care. Just do
Yep.
it, show
Yep.
up because you know what's going to happen. You're going to start feeling better about yourself and you're going to start feeling curious and you're going to wonder what else you can do. And that's how you progress as well.
Absolutely. Well said. Amanda, where can our audience find you to follow you in all of your wisdom?
So probably just my website, which is amandathebe.com. Like all roads lead from there. I'm
Okay.
most active on Instagram though.
Yeah, good. Perfect. And your book, the Menopocalypse, is
Yep.
I've got it linked in the show notes, so be sure to
Okay.
check that out. But you can find it on Amazon. Yes.
Yep. You can find it anywhere actually that books are sold and even your library. And yeah, it's done really well. It's going to be in its fourth year this year and it's still doing well. It's still a bestseller. And I think it's because I really try to write your best mate's guide to menopause, right? It's not going to confuse you. It's hopefully going to be very helpful.
Yes. Perfect. Well, thank you so much for joining. Thanks to everyone for listening today, and we will talk to you all again in the next Move Daily Talks.